Well, here we are back with part 2 of chapter 45 in Geriatric Emergencies. In this section, we're going to talk about, we'll go through the assessment process of geriatric patient, and then we'll get into some respiratory and ultimately some cardiac issues related to our geriatric patients. All right, so let's start off with the assessment. Of course, it's important to understand and it's important to point out that illness is not necessarily an inevitable part of aging. Now, what we just finished in part 1 of this didn't really sound like that, but it is true that illness is not necessarily an inevitable part of aging. Complaints from older patients should not be dismissed as just getting old. We should listen to them when they talk to us. Aging is a continuous and normal process. It's just part of life. Biological aging results from normal wear and tear, as well as other genetic factors. There's a common misconception that older adults are hypochondriacs. They're often viewed as that because they're often in need of a lot more health care and have a lot more health care related issues. So sometimes we just see them as hypochondriacs because we don't think they understand what's going on. Hypochondria actually is much less common among elderly patients than it is among the younger generations. Older adults often underreport symptoms even when they are very serious symptoms. So when a person seeks emergency care, it usually indicates that there's a real problem going on. It's important to understand what is and isn't part of normal aging. Signs and symptoms of illness may be different in older adults. For example, a heart attack may occur without chest pain. Pneumonia might not cause a fever. Uncontrolled diabetes often presents as hyperosmolar hyperglycemic non-ketonic syndrome, or HHNS, as we talked about in a previous chapter. Some acute illnesses may so simply show as a form of delirium. So let's look at some health conditions that can seriously impact a person's life. Hypertension is one of them that we've talked about before, but remember, this puts a lot of strain on the body in order to try to maintain that high blood pressure, and then the high blood pressure itself puts a lot of strain on the vessels. Arthritic symptoms bring pain and stiffness to the joints, making movement more difficult. Heart disease affects the heart's crucial job as pumping blood. Cancer involves harmful cell growth that can spread throughout the body. Diabetes disrupts how the body handles sugar and leads to various issues. Strokes happen when the brain's blood supply is cut off, causing sudden and immediate damage. And of course, COPD makes it incredibly hard to breathe, limiting daily activities. These conditions truly make living much more challenging for those affected, and this is especially true of the geriatric patient. Multiple health conditions can create challenges for both the patients as well as the healthcare providers that are trying to sort out what's going on. Symptoms of one disease may mask or change the symptoms of another disease. For example, severe arthritis pain might hide the cause of might hide pain caused by thrombophlebitis. Dysfunction of one body system can trigger a domino effect, leading to multiple organ failures as well. It can be hard to identify which condition is causing the specific problems, and then vet out what needs to be treated versus what doesn't need to be treated. Chronic comorbidities complicate the treatment process of acute problems due to medication contraindications and dosage adjustments that need to happen. So these patients bring with them a whole host of issues that make it difficult in the diagnosis and treatment realm. Of course, with all of our scene size ups, we're going to try to make sure the scene is safe and use those standard precautions. We want to identify the mechanism of injury or that nature of illness, and then determine how many patients are involved and if any additional or specialized resources are going to be needed. Be aware of factors that may affect your assessment ability, such as sensory changes, communication skills, and even mental or physical disabilities that's going to have a big impact on your ability to assess that patient. Of course, you're going to start off by making that good and relevant general impression, and look for those potential clues like the living conditions, the social and family environment, activity levels, medications, the overall appearance with respect to nutrition, general health, cleanliness, hygiene, and all that, attitude towards mental well-being. We can use the GEMS diamond to form a general impression similar to what we use for the pediatric assessment triangle. We're going to use the GEMS diamond because it has 4 points. It's not a triangle, it's got 4 points. So what we're going to do is the G is for recognizing the patients, recognizing that it is a geriatric patient is the G part. Assessment should be geared to possible problems of this particular population. Remember, signs and things may present in atypical fashions in this group as well. E stands for environmental assessment for clues to the patient's condition and emergency. Is the home too hot, too cold, well kept? Is it secure? Are there hazardous conditions that are present? It's really important to find some of those risks that are there in order to prevent future incidents and accidents. M stands for medical assessment. Older patients may have numerous health problems and take many prescriptions, both over-the-counter and herbal medications. So it's important to obtain a thorough medical history. And S stands for social assessment to determine if a social network exists. Elderly patients may need assistance with activities of daily living, and there are social agencies that can give patients a listing of several of the services that can be provided. Look at the home condition, because this table actually kind of covers the GEMS diamond, but it looks at the home condition. This helps to prompt caregivers to evaluate the home for hazards like poor heating, cooling, safety issues, smoke detectors, those kinds of things. There's also a focus on whether the basic needs are being met, like access to food, hydration, and the living space is safe and comfortable. It looks at and it considers the patient's physical abilities and any adaptive equipment that they might need, such as wheelchairs and handrails and those types of things. And then lastly, this looks at addressing the availability of medical care and support by asking if the patient can access the necessary medical services that they need to help to treat their conditions. The most important task is identifying those life-threatening conditions and then providing the best possible treatment based on the skills and resources that we have available. And then determine that transport priority so that we can transport the patients that really need to be transported quickly. We can do so promptly. Whenever possible, transport patients to a facility where they have been treated before, because they're going to be most familiar with the conditions that they're dealing with and more than likely have their primary care physician that's going to be close by. Use good communication skills to build trust. When you're working on getting a history from them, start by introducing yourself and addressing the patient respectfully, Mr., Mrs., those kinds of things. Use the patient's name and avoid terms like buddy, honey, grandma, sweetie, those kinds of things. Speak slowly, clearly, respectfully, without raising your voice. Try to get the patient's history directly from the patient whenever possible. Be sure to practice active listening by paying attention and waiting for the patient to answer. Notice the patient's tone for signs of fear or confusion. Watch for nonverbal communication because this matters. Be mindful of your eye contact, your gestures, the posture that you're taking, your facial expressions, and those kinds of things, because these can send a different message than what you're intending to send. Position yourself in a way to where that you can communicate face to face with the patient in good lighting without giving the impression that you're towering over them, and encourage the use of hearing aids or glasses whenever those things might be needed, and bring those things along with you when you transport them to the hospital. Try to your best to explain clearly while preserving the patient's dignity, especially when there are other people present. A comprehensive history is going to include chief complaint. It also covers the history of present illness and any pertinent medical history that may kind of go along with that. So it's important to review the patient's current healthcare status and needs along in line with this history taking assessment. Pertinent medical history is going to include current cardiovascular health, exercise tolerance, gathering information about the patient's diet history, getting a good review and a good list of all medications, asking about smoking or drinking habits or a history of those, sleep patterns, and even including intrinsic and extrinsic factors that may have an impact on their health. Determining the chief complaint can sometimes be challenging because patients may think their symptoms are just part of aging. Some patients ignore the real symptoms to avoid being seen as hypochondriacs, or they don't realize that those real symptoms are the root of the problem. Others fear that diagnosis or treatment might threaten their independence, so they kind of hold back. Patients underreport serious symptoms, but mention them in vague or minor ways, or they'll bring up those really, incidental seeming symptoms is what they'll complain about. They might withhold symptoms when other family members are present, again, because they feel that this may threaten their independence. And patients may have multiple chief complaints from different sources, so it's not unusual for them to have several issues that are kind of going on all at once. So here's some screening questions that we can use that'll help kind of narrow things down. When we're talking about the cardiovascular system, we can ask some questions about, is there any chest pain or discomfort? If so, when? What about pain in the left arm or jaw? Have they noticed any fluttering or rapid heartbeats in their chest? With the respiratory system, we might ask, do you get short of breath? If so, when? Any history of a recent cough? Is it painful when you cough? Is there a color to the sputum when you cough? What position do you sleep in best? What's the most comfortable position for sleeping and setting up? Neurologically, why did you call 911? Why are we here? Did you call or did a family member call? Have you had any dizzy spells or fainting? Have you had any trouble speaking? Recent headaches? Any unusual weaknesses or strange sensations in your arm or your legs? Gastrointestinally, we'll ask if there has been any recent changes to appetite, any weight gain or weight loss, changes in bowel movements, and whether or not there's any nausea or vomiting. And in the genitourinary system, see if there's been any pain or difficulty urinating, changes in urine color, changes in urination frequency, and if any answers are positive, follow up with more detailed questions. This helps to ensure that no symptoms are missed, even if the initial complaint seems minor. So this list will be asking all of these questions in this way is going to be really, really helpful to make sure that they're not covering up, holding back on anything that's underlying, or they're just kind of dismissing some of those things as that they don't believe they're important. So after you identify that chief complaint, we're going to drill down into it, and we're going to focus on that history of present illness and take a detailed history of the problem. Chronic issues may complicate the acute problem that's going on, so we need to keep that in mind and make sure that we ask some key questions that will clarify things to help us distinguish versus acute versus chronic symptoms. So we can ask things like, how does this differ from last week? What happened today that made you seek help? What's different about this? And of course, get that sample history, because that's going to be really, really helpful in understanding what's going on, and it's going to give you some background information as well. Get a detailed history of the patient's medications. Get all medications, prescription, over-the-counter, herbal medicines, all of it. Get all of it in there. Ask the patient for a list of medications by name, along with the dosing and the frequency. We should also include any prescribed medications that are not currently being taken and medications that may have been provided by other sources. Always ask for permission to take the medications to the hospital with you. Ideally, you bring the medication bottles with you and not just a list. But if it's a list that you got, make sure that you can try to take that list with you because that's going to be really helpful to the hospital staff. When we move on to that secondary assessment, you want to modify your approach when performing this on an older adult. You want to try to make sure that you minimize the amount of physical manipulation that you do with them, because older adults are more susceptible to hypothermia. We want to do things also that's going to help to keep their body temperature stable. And this is important too when we're going to be transporting them outside, moving them from the house to the ambulance, in very cold environments. We want to take that into consideration as well. But when we're assessing different body parts, we want to make sure that we cover them back up if we're in cold temperatures. Or if we notice that they're very warm to the touch and they're layered in blankets, we might need to take some of those blankets off to help the bodies cool. Multiple layers can obstruct inspection and palpation, so sometimes we got to remove some layers. But ensure that the patient is covered after you've completed your assessment so that we can maintain modesty and body temperature when it's important to do so. So postural blood pressures often differ among older adults. These changes increase with greater frailty and raise the risk of falls. So significant postural shifts in blood pressure and pulse may suggest hypovolemia or an excess of a particular medication. So when a patient is suffering, it's important to realize that they're going to have some postural changes related to their blood pressure and their heart rate. But when they're significant, that's outside of the normal, and we should start to look for other causes of that. If the blood pressure is often elevated, it may be within normal range, but it could actually be an indication of hypotension. So we want to make sure that we establish the patient's baseline blood pressure if possible. So when you take a blood pressure, sometimes it's important to ask, is this normal? So the blood pressure may be low or it may be slightly elevated, but that may be normal or abnormal for that particular patient. So it's important to ask if they're familiar at all with what their blood pressure normally runs. So consider measuring vital signs also in both arms and checking pulses in all extremities to look for dependent edema, dehydration, and of course the overall circulatory status of the patient, noting the differences that you find. Look at the respiratory rate. Tachypnea may be a sign of acute illness. Even if other signs appear to be normal, remember they may not show some of those traditional signs. Listen for lung sounds in all fields, in the front and in the back, and listen for carotid bruit. So listen over the veins in the neck and look for jugular vein distension. Check for the presence of upper and lower dentures, see if they have dentures in place, and be aware that pulmonary crackles may be present without any underlying pathology. So just because you hear crackles doesn't necessarily mean that there's something going on that's going to require immediate treatment, like Lasix or anything like that, or breathing treatments. Edema may result from chronic venous insufficiency rather than right-sided heart failure, and this is why we typically are going to hold back a little bit on the treating on that, or at least begin to question it when we're dealing with geriatric patients. We want to make sure that we're treating the right thing. And then, of course, we're going to reassess frequently, as older adults can deteriorate quickly, very similar to our pediatric patients. Go back through that primary assessment, look at the diamond again, recheck vitals, and recalculate the patient's complaint, or reevaluate the patient's complaint, or you might recalculate it. Reassess all interventions and address treat any changes in the patient's condition. All right, so let's talk about some respiratory conditions. Respiratory conditions are very common in geriatric patients, and it's something that we run on quite often. Pneumonia is, of course, an inflammation of the lungs caused by an infection. It may be caused by a bacteria, a virus, or some other organism. It's purely an infection of something. Something's in there. Pneumonia actually has the greatest impact on the very young and the very old in adults, especially those at higher risk. Older adults, of course, are much more vulnerable, and then people with underlying health conditions are at much higher risk, and those conditions include things like COPD, diabetes, and of course vascular diseases. Individuals with weakened immune systems are more susceptible. Those include patients with AIDS, those undergoing cancer therapy, and even organ transplant recipients. People who are immobile, bedridden, or have conditions that limit deep breathing are also at higher risk. Now, some patients may be immobile or bedridden because of a recent surgery or a broken hip or something like that. Those situations can lead to an increased risk of developing pneumonia. Symptoms of pneumonia in an older patient may appear differently than that of a younger patient. They may appear with acute confusion or delirium, which is not at all uncommon. The body temperature may remain relatively normal, and they may have a minimal cough, or they may not have a cough at all. Abdominal pain can occur, and they may have bronchi that can be heard in the affected lobes of wherever that pneumonia is located. And wheezing is not unusual with them either. Treatment is going to primarily be supportive and focus on managing the symptoms. We're going to provide fluids, but we're going to be cautious with that. Oxygen by nasal cannula or mask, depending on where their O2 sat levels are. And analgesics can actually help to reduce fever. Preventative measures can help to reduce the risk of pneumonia, so there's some things that can be done to prevent that risk. There's a vaccine for that, and then of course booster doses maybe need to be given every 3 to 5 years. Stopping smoking is another thing that lowers the risk, and performing respiratory exercises while they're bedridden can actually help prevent infection. These are exercises that they do even in younger adults post-surgery while they're still in bed before they're able to move, even if it's for a short period of time, for 24, even 48 hours kind of thing, before those people are released from the hospital. They have them doing breathing exercises. So for a geriatric patient, it's equally as important. COPD includes a group of diseases marked by bronchial obstruction and airway inflammation. Bronchitis, emphysema, and asthma are all included in that. This is not something new. We've talked about this in the respiratory section, a little bit in the pediatric section, so nothing's really changed here. It's just that it's different in the way that it's going to impact the elderly patient. It's often difficult to distinguish the different types of COPD, which can lead to incorrect diagnosis and treatment. Symptoms reflect age-related loss of lung elasticity and reduced ability to fight infection. These changes can worsen the baseline disability and increase the risk of acute exacerbations, often triggered by an infection. The patient may have shortness of breath during physical activity, and in advanced stages, even minor physical tasks like walking to the bathroom or to the kitchen or to the bedroom can be quite difficult. Preventative measures for COPD are going to include those things like they do with every age level: quitting smoking, avoiding exposure to environmental pollutants, and of course, especially with the geriatric population, is getting immunized against the flu and pneumococcal pneumonia. Long-term oxygen therapy is recommended for patients with low oxygen levels. Pulmonary rehabilitation can help improve lung function and quality of life, and treatment may involve inhaled beta-adrenergic agents and inhaled oral steroids. That's tricky. Too many vowels. General treatment for COPD may include oxygen, bronchodilators, and CPAP. Realize this is going to be depending on what particular form of COPD that's going on with them. Realize too that asthma can actually begin at an older age with symptoms such as shortness of breath, chronic nighttime cough, and wheezing. So it's not just something that's going to occur and start in young age. Oftentimes, though, with asthma, it's something that maybe they had at a younger age that's now reoccurring. Now that they're losing some of the pliability and elasticity of their airways, it's starting to show up again. Management is generally the same for all patients, but make sure we use a little extra caution when we're treating asthma alongside some of the other heart diseases. Remember, those beta adrenergic agents that we give can cause some issues, some other cardiac symptoms in these cases. So we want to take a little extra precautions with those and provide some extra cardiac monitoring and monitoring blood pressure and those kinds of things when we're dealing with those. Pulmonary embolisms are possible. And of course, this is when a blood vessel in the lung gets blocked by a clot. It can lead to irreversible lung damage or an infarction. The embolus may originate from a damaged heart or veins in the lower limbs is typically where it comes from, such as the pelvis or abdomen. Deep vein thrombus is a very common cause, and this has a lot to do with being bedridden or bedfast. Prevention depends on the patient's risk level, so it all depends on what the risk is how the prevention is going to go about it, whether they're on blood thinners or something along those lines. Surgical patients are at the highest risk and may need some anticoagulant medications or compression socks. Risk increases with age due to greater mobility, increased vascular status in the legs, and bed confinement, reducing blood flow to the legs and feet. Older adults are also more likely to have diseases linked to pulmonary embolism, such as cancers, heart attacks, cardiac dysrhythmias, and a whole host of different clotting disorders that may be there. In older patients, the classic triad of symptoms is shortness of breath, chest pain, coughing up blood, and this can be altered or may not be present at all. Pulmonary embolism may be silent or show only rapid breathing. If we suspect a pulmonary embolus, examine the lower leg for swelling, redness, warmth, or tenderness. You're going to notice one leg may be redder and warmer than the other. That's usually an indication that there is a deep vein thrombosis, and part of that is probably broken loose and entered the lungs. Realize that these deep vein thrombosis can be quite large. They can span the length of feet, 3-4 feet in length, and pieces of it can be continually breaking off, and that's why they're particularly dangerous and they need to be treated quickly. If you notice that there's an issue with the leg, be sure to handle it carefully, because we can easily break off more pieces of that, and watch for changes in breathing. Pre-hospital care is mainly going to focus on supporting the airway, managing breathing, and keeping those oxygen levels maintained. Realize you're really pretty much kind of behind the 8 ball on these, because there's not really much you can do in the field, and the lungs are just not perfusing because there's a blockage. All right, so that's a quick rundown of respiratory issues. Let's take a look at some cardiovascular conditions, and then we'll finish out section 2 right here. Heart disease, of course, is the primary cause of death in older adults in the United States. Coronary artery disease is at the top of this list of causes. About 80% of deaths related to coronary artery disease happen in people over the age of 65. Chest pain in older patients may be less intense, atypical, or even absent, so they may not notice that this happens. Older adults may instead report shortness of breath, fainting, weakness, confusion, nausea, vomiting, and fatigue. Always maintain a high suspicion index for acute coronary syndrome in older patients presenting with any symptoms between the waist and the nose. That's really good advice. So if they've got some symptoms between the waist and the nose, we should be looking at the possibility of cardiac involvement. Performing a 12 lead EKG on these patients is essential, and it'll give us a much greater indication of what may be going on. When it comes to heart failure, individuals age 65 and older are at the highest risk of congestive heart failure. Risk factors are going to be things like biological sex, ethnic background, family history, long-term alcohol use disorders, smoking, and the presence of multiple other medical conditions is going to place them at a higher risk factor. Of course, prevention is the key for heart failure. Stopping use of tobacco, healthy diet, maintaining a good blood glucose level. Exercise is a big part of managing heart failure. Of course, weight control and getting blood pressure under control as well is equally as important. Acute exacerbations of heart failure cause pulmonary edema. Symptoms are going to include things like shortness of breath and orthopnea, where they're short of breath when lying down and it gets better when they sit up, which is very common. Mental status changes can occur due to reduced oxygen delivery to organs, and patients may feel a sensation of a hunger for air, like they're having trouble getting enough air in. Whereas, remember, with an asthma patient, they struggle getting air out, or heart failure patients are going to have struggles getting air in. Peripheral edema might signal worsening heart failure. If no other symptoms are present, it could indicate other circulatory, skin, or infection-related issues. So absent, the other signs and symptoms of heart failure, it could be something else. Bedridden patients may actually show some sacral edema as well. In older adults, the presentation may be obscured by signs of aging or overlap with other chronic conditions. For example, symptoms like shortness of breath on exertion or easy fatigability. These are not uncommon with geriatric patients. So, what we need to do is really drill down into those and find out if what's going on today is abnormal for them in their current state. Acute exacerbations are frequently associated with poor diet, not following medication regimens, and development of dysrhythmias, as well as acute myocardial ischemias. Pre-hospital treatment is going to be similar to other populations, but it's important to be familiar with the patient's medications and how that may affect your treatment plan. End-tidal CO2 should be evaluated immediately and continuously monitored throughout the transport process. Treatment should include careful monitoring of fluids to prevent fluid overload. This is very important with these patients. If there's the slightest suspicion, if you're trying to rule out between heart failure and something else going on, heart failure and hypovolemia, make sure that you're slow walking the fluids just like we do with the pediatric patients. Very small incremental increases while you're continuously monitoring the patient. CPAP use is really helpful, and of course reaching out to medical control that may be necessary in some cases. Remember that fluid imbalances can actually worsen heart failure, so we need to balance the need of IV fluids against the risk that they're going to create if they get too much fluid in them. Even a small amount of fluid change can lead to some serious complications with these patients. Remember, we should treat them like they're very fragile. Administer vasopressors according to local protocol if there is hypoperfusion, and this vasopressors may be a better route than jumping straight to fluids if there's a hyperperfusion issue. Dysrhythmias in older adults are typically caused by age-related changes to the heart. Remember, we talked about some of those changes. There may be some pre-existing cardiac conditions. It could be side effect of medications, or it could be an altogether combination of any one of these or multitude of these factors, and we need to take that into consideration. Atrial fib raises the risk of stroke and heart attack, and it can cause blood to pool or even stagnate. Patients are typically on a regimen of medications that have diagnosed atrial fib. So ask them if they have a known history of atrial fib, and this is going to be helpful in knowing whether or not it's being treated correctly. Bradycardias occur more often in older adults due to the aging conduction system. So beta blockers or calcium blockers can reduce heart rate. Even relatively benign issues like constipation may cause bradycardia because they're straining to go to the bathroom. Often these are managed with an internal pacemaker. So once these kind of go over the tipping point, we'll start to see patients with pacemakers that are installed on them. Sometimes they'll actually install pacemakers on our atrial fib patients as well in order to manage that rhythm too. About 70% of U.S. adults age 65 and older have hypertension. This is actually becoming, and I know we're talking about geriatric patients here, but this is actually becoming something that's much more commonplace in patients in their 20s and 30s as well. But 70% are over 65. Most experience isolated systolic hypertension due to a loss of arterial elasticity, so it's mainly the top number. And of course, managing systolic and diastolic hypertension reduces the risk of stroke and heart attack. So it's important that their hypertension is managed and managed well. Hypertensive emergencies need carefully controlled blood pressure reduction, which often cannot be managed in the field. So this is not something that's easy for us to manage in the field, especially with geriatric patients, because of the risks of tipping them the wrong direction. Nitro is generally not recommended for hypertensive emergencies. When rapid onset of symptomatic systolic hypertension occurs, treatment's going to involve antihypertensive therapies. Elevate the patient's head at a 30-degree angle during treatment to help reduce the amount of intracranial pressure, and you're going to need to transport them relatively quickly. Aneurysms is a weakened area of the heart of an artery that causes a balloon-like defect, weakening the arterial wall. It can be congenital or it can be acquired. Factors that are going to contribute to the development of aneurysms are things like atherosclerotic disease, obesity, and of course, big on the list is hypertension, especially uncontrolled hypertension. The likelihood of developing aneurysms actually does increase with age as those arterial walls kind of get less elastic and they're less forgiving. A new headache or a change in the pattern of a chronic headache may signal that there's an early sign of cerebral bleeding. The initial sign is often sudden, with a sudden and severe stroke. Use of anticoagulants can worsen the effects of an aneurysm, so it's kind of a catch-22, a bittersweet kind of thing for patients that need to take anticoagulants because it does increase the risk of a stroke. Preventative actions to manage the risk. Risk factors are linked to hypertension and atherosclerotic disease. This is going to include maintaining a proper diet, getting good exercise, quitting smoking. You know, this hits the list on every one of these is quitting smoking. And when we talk about quitting smoking, it's not just quitting smoking, it's quitting the use of all tobacco products because of the effects of nicotine and tar and all those things on the body. And of course, this throws in there controlling cholesterol levels as well. Thoracic aneurysms typically show no symptoms until they grow very large or rupture. Early signs may include difficulty swallowing, hoarseness caused by pressure on the laryngeal nerve. Abdominal or back pain may be present with abdominal aortic aneurysms or AAAs. Thoracic and abdominal aneurysms that are asymptomatic, not expanding or below the certain size, are usually managed without surgery but require regular monitoring. So until they reach a point to where that they need surgery, they're just going to be monitored. When an older patient reports back pain, conduct a thorough exam of the chest and abdomen. And treatment of abdominal emergencies is surgical. So the ultimate goal is they need to get into surgery. So we need to make sure that we recognize that the problem that they're having early, perform the necessary assessment, stabilize them. But remember, we're not going to dump fluids to them. We just want to get them to a brain perfusing point, because the more we raise the blood pressure, the more that aneurysm is going to bleed. And we need to provide rapid transport to a facility that can do immediate surgery on them. So it's going to be a facility that has 24/7 surgical abilities. All right, that is part 2. We've kind of gotten through the initial section of a history of geriatrics and kind of how they differ, patient assessment techniques, covered a couple of topics. We're going to come back with sections 3 through 5, and we're going to cover quite a few topics in those sections. So we'll see you back at the section 3.